Welcome everybody to BlockHeads for November of 2024. We have two fantastic guests to discuss long-acting blocks with Dexamethasone and Depo-Medrol. Because I always said droperidol again. Sorry. So I'm going to hand it over to Mike, and you can kind of take over and introduce our guest speaker as well. Thank you so much.
Thank you so much. My name is Michael Polisuk. I'm an emergency physician up in the Greater Toronto area. Work out of William Osler, the POCUS lead there, and have been working to getting some blocks going and getting all of those things sorted. But I reached out to Jinli Li, Dr. Jinli Li, who's the director of regional anesthesia at Yale, and has published a bunch of very interesting articles on extending blocks beyond the typical dexamethasone, bupivacaine, by using methylprednisolone acetate, or also known as the brand name Depo-Medrol, and has been having some fantastic results. So just as a quick plug, Jinli, if you're okay, I did use your protocol, which with a few of my patients. I had one patient, 90-year-old male, 6 ribs fractured on one side, refused to stay, came back the next day because he's in too much pain, gave him a single shot block. It was a paravertebral / ITP ESP kind of combination block. And then was looking at the EMR every single day to see when he was actually coming back, and he didn't show up. And so 7 weeks later, I gave him a phone call, and he said that block was fantastic. I had no pain. And so he had 7 weeks of multiple displaced rib fractures from a single shot block using your protocol. And then I had another gentleman that I did a bilateral lumbar ESP / QL3 sort of blocks as well for lower back pain. And he couldn't walk in the emergency department, did a block. I didn't actually see him because he left after, despite me wanting to see him. So he walked out, and then I called him 5 days later, and he said, "This is fantastic. I've taken nothing else." And then I called him 2 weeks later, and he said, "Still fantastic. I have taken nothing else." So maybe a game changer. I know you're using them for a whole bunch of different things. So please tell me where, just how did you get to this part? Actually, let's start with what's the I'm coining it for you. What is the Yale Li regional protocol? Or we'll call it Dr. Li protocol. We'll just call it what is your protocol, and how do we make it famous?
Well, first of all, thanks, Michael, and thanks for everyone to be here. When I started, it was 8 years ago. When at Yale, we're trying to set up ambulatory total joint program, total knee, total hip. I didn't know better, so I went to the surgeons and said, "Do you want me to use that long-acting local anesthetic on the market?" I won't name it. And then the surgeon looked at me and said, "Jinli, our literature said it doesn't work. Does your literature show it works? If it works, we'll use it." I was like, "Oh, our literature doesn't support that either. Okay, let's look for alternatives." So at that point, we were doing continuous femoral and continuous gluteal sciatic nerve blocks for the total knees. So I started with dexamethasone. That's the go-to one, right? It works. It prolongs the block for 6 to 8 hours, but pretty much that's all it does. It's not sufficient to set up the protocol. So I went to my chronic pain colleagues and said, "Hey guys, what is your number one most commonly used particular steroids?" Because even though there's evidence shows, if you look at the New England Journal of Medicine, they will say sometimes when they do the facet joint epidural injections, they stay away from the particular steroids because of the risk of complications. They say dexamethasone is just sufficient by itself. However, if you talk to the chronic pain docs, they all tell you the particular lasts longer. And then we said, what's the most common ones? Depo-Medrol. And then I further look into, if you look at the size of the particles, different particular steroids are different. And the Depo-Medrol is one of the largest. I tried the different ones, and this one gave me the longest duration. And the next one I'm looking at, I'm saying, you know what? I'm using 2 steroids. People are so worried. Not the surgeons, actually, very interesting. I tell the surgeons, I say, "Hey, I'm giving 10 milligram dexamethasone, 80 milligram Depo-Medrol for total knee, total hip with other blocks." And they just said, yes, Jenny, can you give 10 milligram IV Decagon in the PACU? I'm like, did you hear what I just said? I gave you that much steroids. It's like, yeah, I heard you, but can you give 10 more IV? I'm like, no. But my surgeons actually are sending the total joint patient home with a 5 milligram Decagon for 3 days. And they claim that even works better than the current protocol. Want me to do a study, so I haven't gone there yet. But I did try to replace dexamethasone. Yeah, right? Replace dexamethasone with some other medications, let's say Presidex. It works, but not as good as the combination of dexamethasone Depo-Medrol. So I will use Presidex plus Depo-Medrol in patients poorly controlled diabetes, like type 1, poorly controlled type 2. I worried about the control. What I do is I actually give less dexamethasone, not less Depo. So I did a study with, if you look at the serum glucose after perineural dexamethasone alone, or the similar dexamethasone plus Depo-Medrol. If you look at the post-op day 1, the serum glucose, fasting serum glucose, the combo is actually lower than the dexamethasone alone, which makes sense, right? Because the Depo-Medrol is lipophilic. It basically drags everything, slows down the absorption. Dexamethasone slows down absorption of the local anesthetics. That's why I make it longer. So it gives you a very slow increase on the serum glucose, rather than dexamethasone give you a quick one, lasts about 24 hours. So that's how we settled with dexamethasone and Depo-Medrol. Most of the patients, opioid naive patients, if I'm doing just one block, I give 5 milligram dexamethasone and 40 milligram Depo-Medrol. And for the whole patient, most of the time, let's say I'm doing 4 blocks, I don't typically go more than 10 milligram to 80 milligram. However, if this patient having a big procedure, let's say a laparotomy, a spine procedure, then I gave 120. I'll just give you one example. Actually, just last week, I have a 26 years old female. We're going to write it up. Coming back for the 3rd back surgery. And the surgery is from T5 to pelvis, basically the whole spine, right? And this is the 3rd surgery from lower lumbar to pelvis. So we did, patient had a 10 milligram methadone intra-op, 40 milligram ketamine, and we did ESPs. But my key of the ESPs, I did multiple injections. I basically did 4 injections on each side. She's so small, I cannot use higher concentration local. I actually use 0.25% of bupivacaine. I did basically 8 injections, 4 on each side. The next day, I saw the patient. Patient's in the room, in street clothes, lying down over there, has been walking around. And the next day, post-op day 2, I didn't even get to see the patient. The patient went home before I would round on the patient. I round the patient at 11 o'clock. She's gone already. So we call the patient. Now this is, when did she have the surgery? She had surgery last week, May last week. And we called her over the weekend. She's like, I'm only having Tylenol. And I took shower already. I'm walking around. And this is like a spine surgery from T5 to pelvis. Not even the first one. And she's not taking any opioids, just Tylenol. And then the other thing is, it's amazing, right?
Go ahead, sir.
And if you for your substance abuse patients, I had a patient who was on, what was the name of the IV buprenorphine? What was the name again?
Oh, Sublocade is the IM injection, but
IM injection. So that patient, the substance abuse patient, just had IM injection in the morning, coming in wrist fracture. This kind of patients, there's no opioid receptor for you to use. Everything is occupied with Suboxone, right? So the surgeon has to have surgery, and then they come over to me. They say, is there anything you can do? So this is what we did. We did a single injection, dexamethasone, Depo-Medrol, bupivacaine. And that patient, when we call, they say, how much pain do you have? 7, of course. But this patient never returned to the emergency room. Don't you think that's a success already for a substance abuse patient? 0 opioid receptors, had a wrist fracture surgery, never ever had any opioids. That's a huge success. And in terms of the motor block, you ask me, right? How about the motor block? It actually does not prolong the motor block. So my shoulder surgeon desperately want me to start the study. If you guys want to help me enroll the patients right after protocol, I'll do it. So for intrascaling block for the total shoulder replacement, I gave 5 milligram dexamethasone, 80 milligram Depo-Medrol. You have to give 80 for the shoulder because the blood circulation is just so quick. 4 or 5, so I do the block pre-op. 4 or 5 hours later in the recovery room, the patient gave you a full squeeze, full hand grip, and they have no pain. And this lasts pretty much all the post-op. You know, the surgeons loves us when that happens, right? Intraoperatively, there's like a 20-25% chance the surgeons are going to injure the nerves. The axillary nerve is right on the humor. And they're worried, right? So in the recovery room, the patient gave you full squeeze. They're happy. I'm happy. I'm happy. I did not injure the nerve by my block. They're happy. They did not injure the nerve intra-op. Later on, those patients, they're going to be in the sling for a week or two. They have a lot of issues post-op. Your cubic tunnel compressions, cubital tunnel, and the carpal tunnel suppressions. All of the brachial plexus nerves can be involved post-shoulder procedure, not from the surgery, not from the block, it's from the slings patient position. So this is huge for the surgeons, huge liability for them to come out of it. So a lot of things we can do for those part. Long answers for your short question.
Yes, no, I mean, and it sounds fantastic. And you're using them for all of your total joints, if I'm correct, right? So you're using
all my total
dexamethasone
joints.
and Depo-Medrol for every total joint.
Yeah. And I have an ongoing study for comparing the long-acting local anesthetic on the market. The one you cost about $300, $400. And the other one is the dexamethasone plus Depo-Medrol. So the patient coming in, I have a unilateral knee study, I randomize the patients, but I have a bilateral knee study patient. So the patient coming in, they're having bilateral knee. I basically randomize them. One knee is the other medication, one knee is our protocol. And we follow up the patient for 30 days. The patient's like, you keep asking me if there's any difference. There's no difference. Stop calling me.
No, sorry, this is between the long-acting.
The one on the market, the longer-acting, the market and our protocol.
The long-acting bupivacaine and your protocol. So there's no difference between those two. Okay, wow, that's great. Are you using...
ask...
Oh, go ahead. Yep.
Asking about the infections. I'm telling you the truth. I was worried when I started myself. I don't want to cause any issues. If a single surgery on the planet that what I think I'm worrisome got an infection, it's not a spine surgery. It's the joints. Because if you get into the infection and if you don't cure it with all the subsequent revisions, it's fusion of the joints. That's a huge deal. And I talked to the joint surgeons. They are not that concerned. The reason being, if you look at the early protocols coming from NYU, the early days, 1990s, when the surgeons does local infiltrations, steroids, Depo-Medrol is one of those. So they seems less concerned than us. And we have been doing this for the past 8 years. 2016, we started this. There's no increase of infections. And if anything, maybe there's a decrease of chronic pains associated with that. Think about, you guys may or may not see this because you're in the emergency room, the anterior approach of total hip replacement, they actually, a lot of the time, they injure the lateral femorocutaneous nerve. Right. Just surgically. But after we do the block with that nerve preoperatively, they actually see a decrease of the patients coming back to the clinic to complain about it. Well, think about it. If you have a nerve injury, how do you treat it? You basically give the patient systemic steroids or inject the steroids around the nerve. Just this week, I actually had a patient, obstetric patient, post-op neuropathic pain, really cannot move, screaming. I happened to be on call over there, and I literally did ultrasound guided ESP with the steroids, and the patient said, well, I feel that burning as you inject. And the next thing we know, the patient said, you're the hero. She went home already with that. Neurontin cannot even cure the OxyContin is not working. Neurontin is not working for the neuropathic pain. And this is how we cure the problem. You guys probably see this a lot in the emergency room, the neuropathic pains.
Yeah, I find in my practice I'm using a ton more steroids instead of opioid medications, just because I find that they can be, helpful, and especially in perineural blocks, I find them to be very, very effective at helping out for sure. Quick questions for you. Oh, go ahead. Yeah, you go ahead.
I was just one trick for the patients who are chronic pain, neuropathic pain. If they come to the ED, they want you to do a block. Do not do a block with a local anesthetic alone. Unless you use a huge concentration, super high. The reason being those nerves are irritated, the inflammation, all of those. Local anesthetics are not naive. They actually stimulate the nerve. So they actually make them feel worse. But you give a little bit of steroids, you calm it down. We had the patients literally said, take away your catheter, it's not helping me, it's hurting me. I was thinking, how can that be true? My catheter, I know exactly what it is. And then suddenly they came to me and said, you know what, you need a little bit of steroids. I basically bolus the patients with dexamethasone and the local anesthetics. Suddenly I become the hero. So those are the things that just a small tricks for you guys in the emergency room. Go ahead, Michael. You have a question? You had a question for me?
Yes. No, thank you so much. I mean, oh yes, no, I have so many questions, but but I also appreciate hearing you talk about it, and you're adding so much more to this discussion, which is fantastic. Have you used this protocol for trauma yet? In particular, hip fractures or rib fractures?
Hip fractures, absolutely. And for those elderly patients, whatever block I can do, whatever position they can allow me, right? But definitely will do hip fracture patients. For other traumas, really depends on the surgeons. If they like me to do the blocks, yes, I'll do it. If they don't, then I don't. I don't fight with the surgeons in terms of compartment syndromes. Actually, I take it back once. There's one IR surgeon doing cryo in the lower extremities. Her first patient, so worried about the patient, sent patient home, patient having so much pain, not sure compartment syndrome or from the cryotherapy, actually returned to the ED. So she come over to me and said, is there anything you can do? So what I did is I did a popliteal sciatic block, and I put it on dexamethasone Depo-Medrol. I sent the patient home with an on-cue pump, only 4 cc an hour. And the patient had no pain, and next day starting to move everything. So every day is super happy from that perspective. And then there's another surgeon, actually, a surgeon who is a pediatric surgeon. He does a lot of, congenital problems, very complex. And he gave us very detailed instructions in terms of this one, I want a dry catheter because I worry the compartment syndrome. This one, you can do single injection. So it just so happened that there's one day he told us, you can do single injection popliteal sciatic blocks. So we did it. And he come in, he like, what? I was going to do intra-op neural monitoring. So we did the injection with the dexamethasone, Depo-Medrol, and the local anesthetics. And he intra-op, he was able to monitor the patient. So now he was like, oh my God, I'm so excited. Here, we have to do a study together. You guys are going to do the blocks, and I'm going to monitor intra-op. So I don't have any further information from that perspective, but we are going to do a study on that. So the bottom line for this trauma, I don't have enough experience in terms of orthopedics. You will have to talk to your orthopedic surgeons in terms of that. So for example, the popliteal sciatic block for a regular patient, if I use bupivacaine, I use dexamethasone, the patients are not going to move the toes within 24 hours, right? It's going to last longer. But if I add on Depo-Medrol, typically the block will, in terms of the motor block, will wear off within 12 hours. So if the orthopedic surgeons are not terribly concerned about that 12 hours, then you can do it. You can find a good surgeon. You can say, how about I do a block with 0.2 ropivacaine, 0.5 ropivacaine, and I'll give you small dose of dexamethasone. Don't give a 10 milligram, give 2.5, give 5, and you add Depo-Medrol, and you can see how soon they can return a motor. I guarantee you within 12 hours, they should return a motor. And then if the surgeons will be okay with that. But I don't have enough experience with that because our surgeons was a little bit concerned. I want you, if you guys can try, I will be totally happy. Let's write up the protocol together, like multi-center. We try just a few patients in each center, and we can get it published. That would be awesome.
Yeah, that would be fantastic. And especially because a lot of the times in the emergency department, we're dealing with the traumatic ones, and that's where nerve blocks are really quite effective for us.
If I
in
could
the
just interject
ED.
for
So
one quick second, I apologize.
yes, please go ahead, Dan.
Dr. Li, I just want to make sure that everyone is aware of one thing because people might start stepping out around the 30-minute mark. I think Joe had a quick announcement for fellows that are on the call or anyone who has fellows as part of their group. Joe, if you want to go ahead with that announcement real quick.
Yeah, hey guys, sorry I'm running around, so I'm off camera. But I did just want to do a quick plug for our next BlockHead session, which is going to be for the fellows. So if you guys have a fellow that's doing any sort of research project on December 12th at 1 p.m. Mountain Standard, we're going to have the fellows just do one quick slide and let everybody just sort of follow up with any questions, thoughts, considerations, and similar to what we're talking about now, any opportunities for collaboration. So if you have a fellow, please have them send me a slide and it'll be in the summer email as well. Thank you.
Thank you, everybody. And Dr. Li, thank you very much for allowing us to have that brief announcement. So
pleasure.
feel free to continue with the conversation.
I'm just looking at this as well too. Is there any randomized controlled trial evidence out quite yet for this protocol? I know that's why we're chatting part of it, which is excellent. But I think it would be anything that you're aware of.
I'm running one, but it's a one single center, so it's slow in terms of recruiting. Most of my data is coming from retrospective studies.
But you do have a number of retrospective studies.
I have a lot.
Yeah, which is fantastic. So
yeah, all our surgeries, you talk about all the GYNs, all the gen surge, all the nephrectomies, cystectomies, you name it, every block, all the truncal blocks, chest blocks, all the total joints orthopedics, we're doing that. And to give you one example, we have the robotic cardiac surgery, actually robotic, right? You think robotic is not painful. Actually, robotic cardiac surgery for mitral valve replacement is the most painful cardiac surgery, much worse than the open sternum for the CABG. So they actually didn't really necessarily wanted us to do blocks originally. They said, we're going to do our own local infiltrations or cryo, blah, blah, blah. But then they had the patients re-intubated in the OR, re-intubated in the ICU. So they asked us to do the blocks. So what we did is we did T3, 5, and 7 single injection paravertebrals with dexamethasone Depo-Medrol. And that's ever since then, there's no patients being re-intubated in the OR, in PACU, and in ICU, and they are actually exiting the patients right in the OR. There were once my colleague, he's a big believer, and they extubate the patient, and then there's the ICU on hold. So literally my colleague and the patient, they're just in the OR, had a 20 minutes chat because patient didn't have pain, fully awake. They're just chatting it away in the cardiac room after robotic cardiac surgery. So this surgeon left Yale, and this surgeon made sure before he leaves, he arranged me to meet with the other anesthesiologists in the other institute multiple times. And they want to make arrangement that those anesthesiologists come over to visit Yale to learn the protocol, but Yale made it complicated, so they couldn't come. Yale don't want them to learn, so they couldn't come over here. But he was so happy. But afterwards, after they left, they somehow couldn't replaced the protocol. So now he's doing cryotherapies, all of those, still not happy. It's a good protocol. The key is though, when you use the Depo-Medrol, make sure you mix it really well. So what I do is that I mix the dexamethasone Depo-Medrol with the locals in my 20 cc syringe, and I collect it with a stopcock, and this is my 10 cc syringe. What I'm going to do is I'm going to use my syringe to do hydrodissections. After I'm happy, this is my spot. I'm going to skirt out whatever settings that I haven't used in my 10 cc syringe. And I'm going to mix it really well and inject out of my 10 cc syringe. So the key is you mix it really well. Particularly, you make the preparations of the medications, let's say 20 minutes, half an hour ahead of time, then it's going to deposit in your syringe. So make sure it's better you prepare it just the moment you're going to use it, and then you're going to mix it really well. That's the key for that.
And that's because it's so particulate and it kind of stuck.
And that's why it makes it last longer.
Yeah, well, that's excellent. Question, and so you mentioned or answered many of these things. I know we've only got a couple of minutes left, but if anyone has any questions, please feel free to throw them in there. Suman, sorry, you said this is the first few minutes. We're not talking about droperidol. No, this is Depo-Medrol. Is there any rule of thumb for dosing or any difference with different brand names like Solumedrol? So Solumedrol is not partaken, if I'm correct. It is not.
Yeah, no,
it is an
Solumedrol
IV
is,
formulation. So
yeah, Solumedrol is not okay.
so
Oh,
Solumedrol is out.
yes, not. Oh, actually, I think you asked the one question, why just use the Depo-Medrol alone? I did my studies on that part. So what happens is that Depo-Medrol actually sometimes for at least 25% of patients, it needs about 24 hours to take effect. And your local anesthetic lasts about 15 hours. So in between, some of the patients, you can get away from it. They kick in a little bit earlier, or the local anesthetic lasts a bit longer. But at least 25% of patients, that window, you lost the coverage. And then there's losing battle. The nurses and the patients will say, oh my God, it's not working. Your block stopped working. So that's a losing battle. That's why I added dexamethasone. Dexamethasone, the role is only for those 6 to 8 hours, really break that window for that. So I saw that was one of the questions. In terms of dosing rule, I based a lot of this based on chronic pain docs tell me, and I tried it myself. You can use as low as 20 milligram for a single block. You can use as high as 80 milligram, and it actually have a dose response curve. So 20 milligram definitely works less than 40 milligram. 40 milligram works less than 80 milligram. So it kind of depends on what you want to do. If you have a frail patient, you really worry about a lot of other things, you can give like 20. I rarely use 20 nowadays. I give 40. Like I said, if I have laparotomy patients have a incision from xiphoid to pubic symphysis, then I will actually give 120 for that situation. The majority of the patients, I give 5 milligram dexamethasone, 40 milligram Depo-Medrol for a single block. And if I'm doing a couple blocks for this whole patient, I typically max as 10 milligram dexamethasone, 80 milligram Depo-Medrol. If the patient's chronic pain, if the patient is more than 90 kilo, if the patient's having a major invasive procedure, I go on to 120. And I really found that 120 is making a difference for me. I'll give you another example. A patient had open duodenectomy. In the surgeon who don't typically believe in blocks, we did a block, and the patient stays in the hospital for like 4 days. We went to the OR. The surgeon there said, "Oh, we'll wait." And the surgeon said, "No, come on in." And the surgeon introduced, "This is the team made you pain free." The only thing that patient complained post-op is like, "I'm having so much heartburns over there." So open laparotomies, you can go on to 120. And increasing the Depo-Medrol a little bit is not a problem. Pay attention to your dexamethasone when you have poorly controlled diabetes. If you talk to your chronic pain docs for the type 1 diabetic patients, they still use Depo-Medrol if they need it. Of course, monitoring is indicated, and if you don't have to give a high dose, you don't. What other questions you could ask? I think we'll answer that question.
I think good. This session was designed to be about a half hour, so we really appreciate your time, Dr. Li.
Thank you so
Mike,
much.
thank you for setting up a lot
So
of this
in
stuff.
fragility fractures, I mean, there was.
Oops, sorry.
Oh yes, sorry. Yes, thank you so much.
Fragility fracture. Go ahead and ask your last question.
Now. Oh, was that my question? Sorry. Oh yes. Okay. Sorry. Last question. Thank you again so much. For fragility fractures, any concerns about osteoporosis using Depo-Medrol? Because I know there was some work with epidurals and Depo-Medrol. Maybe there's just not enough evidence quite out there, but nothing that you find in terms of bone healing or anything else in all your joint repairs or other things in frail individuals.
Single dose, and that's one thing. But I do want to point out, the steroids, one of the risks is the patient becomes a little bit agitated. You typically don't see this in younger patients, but if you have higher dose, you do see this in the elderlies. So with the elderlies, I almost never go on to 80 milligram. I typically just stay with 40 milligram. If it's really frail, I'll give 20 milligram. I had a patient 88 years old, coming for total knee replacement. The doctor is actually a physician, knows me, found me online, emailed me, said, you know, I don't know what happened with my mom. You did a blog, she had a total knee replacement and she had no pain. However, she hadn't slept for 2 days, 2 nights. What could be the reason? And there's no other things going on. I said, I know exactly what it is. This is from the steroids. You will be totally okay after that. So with the elderly, that's the only thing that be a little bit cautious about it. They will get that side effects a little bit more. Osteoporosis, we haven't really had it. Well, we didn't really look into it, but we haven't really had any issues from that perspective.
Excellent. If there's no other questions from the group, I think it's only 30 minutes here. Thank you, everyone, so much. Jinli, I'm going to stay on a little bit extra for anyone who's here if you have any other questions.
All right. Thank you very much, everyone. If you want to stick around for further questions, you can feel free to do so. We're going to stop the recording at this time. Thank you.